Hello everybody. Today we will speak about pulpitis and pulp therapy for primary teeth. If you ever seen this cartoon, Hedgehog in the Fog, this is the most famous Russian cartoon, and it's very smart, it's very positive, it's very interesting. My advice for you to look it, to watch it, and sometimes the doctors, the dentist, feel themselves like this hedgehog in the fog because we don't know what the next is waiting for us near our way. If we speak about etiology of pulpitis on children, because, of course we know that it's the most prevalent reasons are acute trauma, chronic trauma, orthograde, and postgrade. Iatrogenic trauma can be mechanical, chemical, thermal. When the doctor, the dentist, works without any rules and avoid some safety things and damage the pulp with excessively strong probing, removal of adjacent tooth, of antagonist tooth, applying the bottom of the deep caries cavity of some strong substances, or sometimes they use strong antiseptics that leads to appearing of pulpitis. Thermal trauma, it's overheating from the preparation without water cooling, overheating when the polymerization regime is disturbed. Chronic trauma, of course, it's overstatement of restoration, excessive pressure of orthodontic devices, anomalies of occlusion again. It's iatrogenic trauma and harmful habits in presence of caries, lesion of the teeth. On the it's the reason of behavior of the patient. Orthograde, of course, the most prevalent reason of in pulpitis is infection factors. It's bacteria from caries cavity. It can be hemolytic, non-hemolytic, streptococci, diplococci, staphylococci, gram-positive rose, lactobacilli fungi. All microorganisms that are exist in oral cavity, and you know that they can go through the wide dentinal tubules, and they lead to occurrence of primary chronic form of pulpitis. And biogenic means products of vital activity of carcinogenic bacteria through wide dentinal tubules can cause primary inflammation of the pulp and cause the development of pulpitis before the penetration of bacteria into the pulp. So retrograde is bacteria from periodontal pockets from the focus of perical inflammation on the upper jaw in permanent teeth, from the maxillary in mandibular. They can go into the apical part of the teeth and leads for the inflammation of the pulp. We have some classification of pulpitis. One of them is classification of Platonov, and we divide acute pulpitis partial and diffuse, chronic pulpitis fibrous, hypertrophic and gangrenous, and the third group is exacerbation of chronic pulpitis. If we speak about classification of Ivanov, it divides acute pulpitis in 4 groups: partial acute serous pulpitis, total acute serous pulpitis, partial acute suppurative, and total acute suppurative pulpitis. And chronic pulpitis fibrous, proliferative, gangrenous, and the third group is exacerbation of chronic pulpitis. If we speak about Goffung classification, Goffung classification, we have acute pulpitis that we divide the Goffin divided in serous pulpitis and purulent or suppurative pulpitis, and chronic pulpitis with three forms like hypertrophic pulpitis, fibrous pulpitis, and gangrenous pulpitis. So in classification of Goffin, we have this part that is about exacerbation of pulpitis. In international classification of diseases, pulpitis divided not otherwise specified: acute, chronic, hypoplastic ulcerative, irreversible, and reversible. The next group is necrosis of pulp. So the pulp gangrene is another group in pulpitis. It's not like pulpitis. Pulp degeneration like denticles, pulpal calcification, and stones. And later about periodontitis, but we will speak about periodontitis in next semester. So, about following criteria are characteristic for reversible. The synonyms is hyperemia or inflamed reversible and irreversible pulpitis. So, reaction to heat. When we see reversible pulpitis, the reaction is normal. In irreversible, extremely increased. Percussion. Reversible negative, irreversible positive, but sometimes it's not the same. Irreversible, usually if it's acute, the percussion will be positive. Pain, recent onset, mild to moderate pain, onset some time ago, and severe pain. And the bottom of the cavity. If we have reversible pulpitis, it's closed and it's irreversible, open, affected by caries and usually soft. So signs when we have reversible pulpitis, it's just caries and exposed dentin, and irreversible deep caries. Symptoms: non-lingering pain to temperature or osmotic changes. And in irreversible pulpitis, intense lingering pain to temperature changes, spontaneous pain, diffuse or referred pain. What are the particular qualities or features of pulpitis in primary teeth? Of course, it's non-deep carious lesion. You remember that when we discuss anatomical and physiological features of primary teeth, we discussed that the enamel is very thin and dentin is very thin. So it's very difficult to imagine that the carious cavity lesion in primary teeth can be deep. So of course with deep it's moderate, non-deep. The rapid expansion of the inflammation in the pulp, because the pulp is very reactive. You remember a lot of cells in the pulp, many vessels, good blood circulation, that inflammation expands very fast. Very important that usually we can see primary chronic pulpitis. This group of pulpitis are most prevalent in primary teeth. Of course, we can explain it, the anatomical and physiological features of primary teeth. Unexpressed pain, no pain radiation. Usually the children have no complaints of the pain according to the pulpitis. The reaction of periodontium, possible extending of infection to the area of furcation and the fistula occurs. It, of course, connected with the structure of the bone during primary dentition. Various status of the pulp in different canals. For example, in one canal can be necrosis, and another it can be just fibrous pulpitis. Rapid expansion of the inflammation from the pulp into the periodontium, and the influence on physical condition of the patient. So, the most important things that we should remember about features, clinical features of pulpitis and primary teeth, that most prevalent pulpitis in primary teeth is primary chronic pulpitis, and possible extending of the infection to the area of furcation and a fistula occurs. I want to remind you why we can see the inflammation in the zone of furcation. Because you should remember that in primary molars, especially in low jaw, very often we can see the additional canals on the bottom of pulp chamber of these molars. That's why the infection can go through these additional canals in the zone of furcation. And for example, on X-ray, we can see, here you can see the cavity, the horn of the pulp involved in the caries process, so we see the pulp exposure, and we see the decreasing of radiolucence in the zone of furcation. Here the same you can see on proximal surface of second primary molar. We can see the horn involvement, the pulp exposure, and you can see the decreasing of radiolucence in the zone of furcation. We understand that infection from the pulp chamber goes through these additional canals to the zone of furcation. And when we perform clinical examination of these children, we very often can see the formation of fistula on the zone of marginal gingiva. It's very, very high. The position of fistula is very high. Why? Because the process of inflammation is situated in the zone of furcation, not in the zone of the apex of the roots. What about acute pulpitis? Acute pulpitis is an inflammation of the pulp caused by injury to the pulp, usually from dental caries or trauma. It is the most frequent cause of severe tooth pain. The pain is caused by pressure of fluids building up inside the pulp chamber or root canal. We usually see this condition only in somatic healthy children. It means now we have a few somatic healthy children. That means that we see acute pulpitis very, very rare. What are the symptoms? A patient with acute pulpitis may complain of the following factors: spontaneous, continuous, or intermittent pain and pulsating pain in the affected area. Increased pain when lying down. Acute pulpitis is very rare, I told you why, because we diagnosed it in somatically healthy children. This form is found only in teeth with fully formed root. So you should remember that acute pulpitis we can meet in children older than 4 years old up to 6 years old, when the roots fully formed, because before we have root formation, after 6 we had resorption of the roots. Partial pulpitis is rarer than total because it's acute pulpitis. It spread very, very fast from the coronal part to root part of the pulp. Pulp cavity is always closed and with mild infecting dentin in the carious cavity. Serous pulpitis very quickly becomes purulent. Sometimes it takes 12-24 hours. And from serous, pulpitis becomes purulent. Acute pulpitis is often accompanied by a deterioration of general condition of the body, and the patient complains of the high temperature, of, for example, headache and something else. The more often outcome of acute pulpitis is pulp necrosis, not formation of chronic pulpitis, but pulp necrosis. So what are the main symptoms of acute inflammation? The sudden emergence of strong toothache, often in the evening or at night. It's very important because I told you before that the pain increased when the patient lying down. Pain is worse from cold or warm, so for temperature stimulus. And if tissue is filled with pus, the pain becomes stronger from hot and cold. From hot and cold calms it down. So it's very important differential sign of the suppurative and serous pulpitis. So when we have serous pulpitis, the pain is worse from cold. When the pulpitis becomes purulent, the pain is worse from warm or hot. Pain during the clenching of the jaws, getting food on the tooth. There may be mild soft tissue swelling and swollen lymph nodes. It's very important to remember that lymph nodes react very fast. Acute pulpitis occurs in tooth with a small carious cavity, and usually it's filled with light, soft, wet dentin. With the development of acute purulent inflammation, the pain is so strong that the child cannot preciously specify a sick tooth, and sometimes the side of the jaw. So the child has pain on the one part of the jaw and can't show us the tooth that it hurts. What about chronic pulpitis? Of course, chronic forms of pulpitis in children are very common and are developing as primary chronic. Chronic pulpitis is usually asymptomatic and often diagnosed during routine oral inspection. Often develops as an asymptomatic process. For example, the child comes for dental examination, we perform it and find that in 1 or 2 or 3 teeth we diagnose chronic pulpitis and nobody know about it before. Often occurs in not deep cavities and very important that with pigmented infected dentin in the carious cavity or in tooth with the filling. So please remember that acute pulpitis we usually find in teeth with white, light dentin, and chronic pulpitis in cavities that is which not deep but with brownish infected dentin. In 40–60% of cases, there is an inflammatory reaction of the tissue surrounding the tooth. So, it's recommended to refine the treatment plan to make an X-ray because it's very important to know the destiny of the bud. The pain at this form of pulpitis appears during the stimulus, getting food in a cavity, cold drinks on the street, and so on. The most common form of chronic pulpitis is fibrous pulpitis, then gangrenous and less hypertrophic. Proliferative pulpitis or hypertrophic pulpitis can occur in children with a closed pulp chamber. Please remember about it. So what about the main symptoms of chronic inflammation? Pain during the meal. The children is trying not to eat at the sick side, and when we perform examination, we can see more plaque or sometimes the formation of calculus on the teeth. In my life, I saw maybe 2 or 3 times that almost all molars on one side of primary teeth were covered with the calculus, and for removing of this calculus I should take tube and bore because it was impossible for using with handle instruments. Sometimes there is pain from the cold water. In chronic gangrenous pulpitis, the main is absent or occurs from hot. Please remember, this is differentiative sign of this pulpitis. When we have chronic gangrenous pulpitis, the tooth often change color. It becomes gray, dark, and differs from others. You can see that it's more grayish. Patient may have a feeling of heaviness in the tooth, a feeling of fullness or tooth knot-like. And there is an unpleasant smell from the tooth. This is about gangrenous pulpitis. When we speak about chronic hypertrophic pulpitis, this diagnosis is very rare and is manifested in the form of overgrowth of pulp tissue in carious cavity when neck pulp is exposed to constant mechanical irritation. The crown of the tooth is badly damaged. And please pay attention that pulp can grow like to the side of cavity, like to the direction of apical part. So, and if the pulp is growing directed to the cavity, we can see the overgrowing tissue in cavity. And if the pulp chamber is closed, the pulp is growing to the apical part, and we can see the formation of fistula. But this fistula will be without any purulent secret. It will be with tissue that can react to thermal stimulus, and of course, when we touch it, will be painful. So when we perform the diagnosis of pulpal fibrosis in children, the first question to ask in regard to a primary tooth with pulp exposure is, should the tooth be retained or extracted? Because it's very important to understand, do we have any complications from this tooth to the bud of permanent tooth? So other important questions are, is the tooth dose for exfoliation? Does the tooth have excessive mobility? Is the extent of infection severe enough to warrant extraction? If the crown of tooth restorable, because if it's non-restorable, there is no sense to save this tooth. Is there a permanent successor to primary tooth? It's very important because if not, the primary tooth may take on additional importance and may need to be treated similar to a permanent tooth with conventional root canal treatment to extend the life of the tooth as long as possible, because this patient will be without this tooth for the whole life. But of course, it depends on the clinical situation, and if it's difficult to save this tooth, we should think about the timing of orthodontic treatment, because the next tooth that will be wrapped, for example, first permanent molar or second permanent molar, can take the place, can make the space shorter between, for example, first premolar and first molar. So you should consult with orthodontist when it's better to save this tooth or not to save. Is this tooth critical to the eruption of other teeth? It may be important to save a primary second molar prior to eruption of first permanent molar. I told you that the first permanent molar is very, very big tooth, and it has their tendency to move mesially, and we can the pre-time eruption of second primary molar can lead the changing of position of first permanent molar, and there will not be space enough for eruption of second permanent premolar. So what are the traditional methods of diagnosis? Of course, we should thorough history of pain. Usually we ask parents, because the child of preschool age can't explain us or tell us the history of pain. Of course, oral examination probing, percussion, palpation, and temperature sensitivity test. We spoke a lot about methods of diagnosis when we spoke about caries diagnosis. So in pulpitis, these methods are most prevalent. So if we ask about pain, of course, it's very important for us to know where it occurs, the intensity, if it's short or long, duration. It happens one by one cases, or maybe once a 6 months, or and so on. Sensitivity to temperature or sugar, so for thermal or chemical stimulus. And of course, it's very important when we speak about temperature stimulus, you should ask about cold and hot. External examination of maxillofacial area. Emphatic, of course, erection of lymphatic nodes, because when we have acute pulpitis or exacerbation, we will palpate the erection of lymphatic nodes, so they will be increased. Face configuration, again, acute and exacerbation, we can see the changing of configuration of the face. Hyperemia and swelling in the area of tooth, usually again in these cases. So, of course, after that we should perform oral examination, and we can see the pulpitis was developed after caries lesion or after acute trauma. Localization, the size of defect, and open bottom of the cavity. It's very important because, again, I repeat it for you once again, that it's differential diagnosis, very important, if the bottom of the cavity is open or not. Clinical tests. Very often we should perform palpation of the alveolar bone, and we can feel during the palpation there's some problem, some empty spaces in the bone. Percussion should be performed very, very carefully because it can be painful and unpleasant for the child. And the degree of mobility. This is for decision should we save this tooth or extract it. On this picture you can see the formation of fistula. I told you before that very often it's formed near the marginal part of gingiva, and we understand that the process located in the zone of furcation, not in apical, because if it was near apical part of the roots, of course, this fistula was mesially or distally and lower than in this position. Of course, when we speak about pulpitis, the radiological examination helps us very much. On this examination, we can find if the bottom of the pulp chamber or the cavity, for example, and the roof of pulp chamber is open or closed. We can find periapical changes. We can see internal or external resorption of the roots. And of course, the most important thing is in the condition of permanent successor of the bud. Of course, the cortical bone near the lamina dura around the bud is very important, the condition of it. About differential diagnosis of chronic pulpitis in children, you see that according to the Goffin classification, we have chronic fibrous, chronic proliferative or chronic hypertrophic, and chronic gangrenous pulpitis. And you see that the pain is absent. When we have chronic pulpitis, there is no pain. Reaction to temperature, to hot. If it's chronic fibrous, long paroxysmal dull pain. In chronic proliferative or hypertrophic, it's prolonged paroxysmal dull pain, which increases when the patient is passing from cold to a warm place, when it's changing the circumstances. For example, in winter time, it comes into the room, and of course, it will lead to pain when the pain occurs. And when we have chronic gangrenous pulpitis, we see prolonged paroxysmal dull pain. To cold, pain increases. In chronic proliferative, no pain, and chronic gangrenous, no pain. Tooth cavity, pulp chamber, in chronic fibrous, it's very often opened or covered with softened dentin. In chronic proliferative, it's open, and I told you, in this case, we often see the pulp polyp. It can be closed. In this case, very often we see fistula on gingiva because pulp is growing in apical direction. In chronic gangrenous pulpitis, usually it's opened or covered with softened dentin. And when we perform probing, just deep probing is painful because there is no pain that reacts for the probing when we have gangrenous pulpitis in pulp chamber. We have just some parts of pulp in root canals. When we perform probing of pulp in hypertrophic pulpitis, it's painful and the pulp bleeds. It's very important for differential diagnosis with periodontitis. And for chronic fibrous pulpitis, there is painful probing at one point on the cavity bottom. Please remember, this is again differential feature. When we have deep caries or pulp hyperemia, the probing is painful on the whole bottom of the cavity. When we have chronic fibrous pulpitis, it's painful just in one point of the bottom. What about pulp therapy? It's like a progression. It can be indirect pulp therapy if we have deep caries. It can be direct pulp capping if we have pulp exposure. It can be pulpotomy when we amputate the coronal part of the whole pulp. And it can be pulpectomy when we remove the whole pulp from pulp chamber and from root canals. So methods of treatment we divided in two groups, conservative and surgical. Conservative methods of treatment are biological method, indirect pulp capping, and direct pulp capping. And we speak about surgical methods. It's pulpotomy, vital and non-vital, and pulpectomy, the same, vital and non-vital. Let's speak about biological method. What does it mean? Indication. Of course, you should often know that indication is just partial acute serous pulpitis, chronic fibrous pulpitis in children from health group 1 and 2, and accidental opening of tooth cavity during the treatment of dental caries. For example, you want to remove all softened dentin, and after preparation you found that you open pulp chamber and you have exposed pulp. In these cases, you can use biological method. Please remember, this method we discussed just in primary teeth and immature permanent teeth. So, additional condition, of course, the patient must be contact. What are the procedures of the biological methods? The first visit, we perform anesthesia, isolation, preparation of cavity, then multiple antiseptic treatment, a sterile solution of antibiotics, antiseptics, or a medical combination of drugs. Drying the cavity by sterile cotton balls, The imposition of cotton ball with antibiotics in combination with the proteolytic enzymes or corticosteroid into the cavity, and temporary filling. The second visit in 1-2 days. If the patient have no complaints of spontaneous pain from thermal, chemical and mechanical stimuli, we perform isolation, removal of temporary seals, antiseptic treatment like in first visit, cover the bottom of the cavity of zinc oxide eugenol cement or calcium hydroxide paste, and temporary filling. And third visit in 7-14 days. If no complaints or objective symptoms of complication from the pulp and periodontal, we perform isolation, remove of temporary sealing, insulating laying, and tooth restoration. So for biological method, we should have 3 visits, 3 appointments, and nowadays we use it very, very rare. Indirect pulp treatment. Indication just 2. Deep caries and hyperemia of the pulp in primary teeth with incomplete root formation with no signs of clinical or and radiographic pulp exposure. In deep caries lesion, we remove the gross caries, allowing sufficient caries to remain over the pulp horn to avoid exposure of the pulp. So it's very important. It's big difference from black theory that we should remove all soft infected dentin. We should avoid to remove the dentin over the pulp horn. So cover thin layer of caries with radiopaque biocompatible base material and seal with the durable interim restoration. Why it should be durable? Because we leave this patient from 6-8 weeks to 6 months. Just after 6-8 weeks or up to 6 months, we should perform complete removal of caries. During this time, the caries process in deeper layer is arrested, and this method has been proved to be valuable therapeutic procedure in treating asymptomatic teeth with deep caries lesion. The procedure reduces the risk of direct pulp exposure and preserves pulp vitality. So, it's very important that we don't disturb this tooth earlier than 2 or 6 months, because this time is necessary to production of the tertiary dentin, stimulated dentin, and the layer of dentin between cavity, between filling and the pulp becomes thicker, and it helps you to avoid the pulp exposure when you perform the final restoration. So you can see on this picture the steps of procedure. The first is anesthesia, good isolation, removal of all caries tissue at the enamel dentin junction, so the walls should be clean without any soft infecting dentin, and just partial removing of soft deep caries dentin. So it's very different. On the walls we remove all infected softened dentin. On the bottom we leave softened caries dentin and perform gentle excavation on the pulpal floor, removing as much softened dentin as possible without exposing the pulp. If you see the changing of the color. The dentin was whitish, yellowish, and then becomes more dark. We understand that the horn of the pulp is very close to the cavity, and we should avoid to remove the dentin from this part. Of course, on this place we should put appropriate lining material such as reinforced glass elastomer cement, hard-setting calcium hydroxide, MTA, biodentin, or zinc oxide eugenol. So these are durable, compatible cement or restorative material. And definite restoration to achieve optimum external coronal seat, ideally an adhesive restoration or preformed crown. So in 2-6 months, we should invite this patient for next appointment. We should remove the filling material, this lame that we used before, like hardening calcium hydroxide, for example, and remove carefully remaining carious material, now somewhat sclerotic, and may reveal a sound base of dentin without an exposure of the pulp. If a sound layer of dentin covers the pulp, the tooth is restored in conventional manner. The use of a base of the calcium hydroxide lana dramatically increases the success rate. So the last sentence I underline for you that this is the result of some investigation. You can find in the literature that some authors are recommended us to use calcium hydroxide liner after this second appointment. Some investigations tell us that you should not use calcium hydroxide liner during this appointment because it has a high solubility, and then we have an empty layer between isolating liner and the dentin, the tertiary dentin. So I think that you should make the decision in each clinical situation by yourself, and of course after that you should rely on your own experience. What is the best, to use calcium hydroxide during second appointment or not to use? The next method, conservative method, is direct pulp capping. It's a method for treating vital pulp exposure. So, for example, pulp capping procedure should be limited to small, less than 1 millimeter exposures that have been produced by accidentally by trauma. For example, the patient fall down and we have the trauma of the crown, or during cavity preparation. Again, you want to remove all softened dentin and you open the horn of the pulp. Of course, should be absence of pain, maybe just discomfort after intake of food, and no bleeding after exposure site or bleeding in an amount. So again, you put the cotton ball for 1-3 minutes, sterile cotton ball, then you remove it and you see that there is no bleeding. This approach has limited application and is generally contraindicated in primary molars, thus it leads to failure. When we discuss the clinical feature, anatomical and physiological features of primary tooth, I underline for you that the pulp of primary teeth is not ready to produce tertiary dentin or secondary or tertiary dentin. That's why this approach of direct pulp capping is not effective in primary molars, and I will tell you in details about this method in next lecture when we will speak about direct pulp capping in immature permanent teeth. Pulpotomy. Pulpotomy, this is the most prevalent procedure when we speak about treatment of pulpitis in primary teeth. This is a method that predisposes the extirpation of vital inflamed pulp from the coronal chamber, followed by medicament placement over radicular pulp, stunts to fix mummification or stimulate repair of remaining vital radicular pulp. So please pay attention for this description. What does it mean? We always use some medicament placement over radicular pulp. We don't leave this radicular pulp just by itself in the roots, because it will lead for the increasing of inflammation and pulp necrosis. So, what is rational in this method? The radicular pulp tissue is healthy and can either heal after the surgical amputation of coronal pulp or be fixed or modified. And of course, it will lead to physiological resorption of the roots of primary teeth, and it will normal situation. Signs or symptoms of inflammation extending beyond the coronal pulp is a contraindication for pulpotomy. What is the signs of inflammation? Of course, it's bleeding. If you can't stop bleeding after 3-5 minutes after putting cotton balls on the orifices of the radicular pulp, of course you understand that this pulp involved in the inflammative process, and you can't use pulpotomy, you should go to pulpectomy. So, indication. So, exposed of the pulp through carious exposure or through trauma. When it's desirable to maintain tooth, for example, primarily for space, function, guidance of permanent teeth, asymptomatic tooth or only transient pain, very, very important, please remember this, that if we have acute pain, acute inflammation, we can't use this method of pulpotomy. Large proximal carious lesion with 1/3 or more involvement of the marginal ridge in the otherwise restorable tooth. Because we know that if we have more than 1/3 of the involvement of proximal lesion, we understand that the horn of the pulp is exposed. It involved in inflammation process. So what are the procedure? Of course, rubber dam isolation, remove caries, open pulp chamber and the roof, amputate pulp with round bore in slow speed running in reverse, or you can use excavator. Then control hemorrhage with dry cotton pellet, or this cotton pellet can be put into formocresol or ferric sulfate. And after that, we place MTA or ferric sulfate or formocresol and place glass ionomer over the floor of the bottom. So why many questions? Because it depends on the material that we use, and we will have different effects on the reduced pulp. So, local anesthesia, good isolation, removing of the caries in caries lesion, then complete removal of roof of the pulp chamber, then removal of coronal pulp tissue with sharp sterile excavator or large round bore in slow speed handpiece, attain initial radicular pulp hemostasis by gentle application of sterile cotton balls moistened with saline, and hemostasis should be achieved within 3-4 minutes, mean 4 minutes. So you can see this procedure. After anesthesia, of course, this is healthy tooth, but it should be with caries cavity. We perform preparation of the cavity, then we perform the deroofing of pulp chamber, then we amputate or perform pulpotomy of the coronal part of the pulp. You can see on this picture, and then we have just pulp in root canals. And of course, we should do something with this pulp in root canals. We can't leave it by themselves. So, what should we use, or what we can use for direct application to radicular pulp stumps to include any of the following? So, we can use 15.5% ferric sulfate solution burnished on the pulp stumps with microbrush for 15 seconds to achieve hemostasis, followed by thorough rinsing and drying. Why we need thorough rinsing? Because ferric sulfate changing the color of tissue, it's usually brown, and tooth becomes more darker. So we should rinse it to remove this solution of ferric sulfate, because you understand the ferric, of course, the tooth becomes darker. And then dry. We can use 20% Buckley's formocresol solution applied to radicular pulp on a cotton balls for 5 minutes to achieve superficial tissue fixation, or we can say it's partial devitalization. And we can use MTA paste or another biocompatible material like, for example, biodentin, bioceramics, applied over radicular pulp with property carrier. So then, well-condensed layer of pure calcium hydroxide powder applied directly over radicular pulp. So then, fill the chamber with zinc oxide eugenol cement, pressing on the zinc oxide with damp pledget to make sure that it's well condensed in the chamber, and place coronal restoration, preferably stainless steel crown. For example, in developed countries, they use crowns. When we use zinc oxide eugenol cement? After ferric sulfate and after formocresol. MTA, you know, this is the very hardening cement, and we can use it by themselves, and biodentin is the same. So when we use MTA, it's not necessary to use zinc oxide eugenol. Zinc oxide eugenol we put on orifices after application of ferric sulfate or application of formocresol. I hope it's clear for you. So the medicaments and materials may change, but excess opening technique will remain the same. Chamber pulp removed and replaced with medicated filling, and canal pulp stays alive. Hopefully, of course, we hope that it stays alive. And of course, excess opening must be large, because you should see the orifices of the root pulp of the root canals, and you can see that this pulp bleeding or not bleeding and so on. Repeat again, we place cotton balls and pressure to control initial hemorrhage. I repeat it for 3-5 minutes. And after that, or instead of that, we can use just sterile cotton balls if we use MTA, or we can use cotton balls with formocresol Buckley solution. We put it for 5 minutes and then restore with IRM cement and cover with the stainless steel crown. For example, some clinical examples for you: divorce, secondary caries, and the same with secondary caries on first primary molar and second primary molar. We remove the fillings. Here we just prepare the cavity. And of course, after that, when we remove the filling, we understand that we have exposed pulp. We perform the deroof, perform the amputation, then we put sterile cotton balls with saline for 3-5 minutes. Then we remove them and see that the pulp is red. It's still alive, but there is no bleeding. After that, we put MTA or biodentin and restore with any filling material, in this case with Vitermer, reinforced resin modified glass cement, or with the stainless steel crown. One more clinical cases, I call this kissing caries. Usually we can see caries lesion on distal surface of first primary molar and mesial surface of secondary primary molars. So in these cases, in both teeth, the pulp was exposed we perform the roof, pulp amputation, pulpotomy, then we put cotton sterile balls on the pulp, then we use MTA, we put in orifices and restore with filling material. One more case, on occlusal surface we have cavity. After anesthesia, deroofing, isolation just with cotton ball, we perform the pulpotomy. After hemostasis, we see that there is no bleeding on the from root pulp. We put MTA on the root on the orifices and restore with filling material. These pictures from the book about pulpotomy, you see very big lesion, cavity lesion. Then we see on the bottom that the pulp exposed and we see bleeding. We open pulp chamber and perform the roof. Amputate pulp with low speed in reverse and see that there is no bleeding after hemorrhage control. But in this case, we see that the bleeding, residual bleeding. Why? Because I told you before, if we see bleeding, it means that the pulp in root involved in process of inflammation, and we can't use the method of pulpotomy. We should maybe it was the mistake, we not amputated pulp in canal orifices. So we remove more deeper the pulp because it was just in orifices, and after that we see that hemostasis was achieved, and we put medicaments and liners. If we speak about the effect of materials on pulp in primary teeth, if we speak about formacrysol, it pulp fixation or partial devitalization, ferric sulfate leads to conservation, MTA biodentin bioceramics to regeneration. These are different effects. Formacrysol was the most prevalent medicament that we use for vital pulpotomy. Anna Fuchs is the author of this method. She's from Israel, and you can find a lot of articles about using of formacrysol, but the last decade we say that the formacrysol can have effect on the health status of the child because it can go from the pulp to the periodontum and to the blood vessels and to the blood and have the systemic toxic effect. That's why nowadays maybe just 1 or 20% of dental schools in Europe give the knowledge about using of formacrysol. The most popular methods of medicaments for vital pulpotomy is ferric sulfate and MTA or another biocompatible cements. And the final restore with stainless steel crown, because the specialists say that after endodontic treatment the crown is not very strong and the walls can be broken under the chewing pressure. So here you see again mandibular first primary molar pulpotomy procedure, control of hemorrhage. You see that the pulp chamber is empty. You see distal canal and mesial buccal and lingual canals, and the orifices are dry. And we can put medicaments that we want. It can be MTA restore, it can be formacrysol, zinc oxide, F-genol and restoration, and it can be ferric sulfate, zinc oxide, F-genol and restoration. When we speak about pulpotomy, I told you when we have hemorrhage, for example, from residual pulp, of course we understand that it involves inflammation and we can't leave it inside the root canals and we should perform pulpotomy. And in some diagnoses like hypertrophic pulpitis, suppurative pulpitis, chronic gangrenous pulpitis, we use pulpotomy. During first appointment, we put devitalizing paste on the whole of the floor for the cavity. What are the pastes we can use? Caustineer Fort, Caustineer Peridentique, Devit C, Debrupin. After 7-14 days, but I prefer 10-14 days, we invite the patient. Of course, we remove this temporary filling and we check the condition of the pulp. The pulp should be painless and without bleeding. If it's in such condition, we can perform the roof with the tubing bore, perform the pulpotomy of coronal pulp, and cover the non-vital pulpotomy. It's not a pulpectomy. It means that when the patient has allergy, for example, for anesthetics, or you are not sure that his behavior is ready for anesthesia, or the patient non-communicable. So in these cases, you use non-vital pulpotomy. And I told you the first appointment, the second appointment, we cover the residual pulp with mummified paste. You remember that the pharaohs in Egypt, when they were putting in pyramids, they were mummified. And their body becomes dry without any process of necrosis or inflammation or some bad things. That's why we use mummified paste to save the residual pulp in root canals. In this case, we use paste with pyroformaldehyde. It can be Tempofor, Cresapat, Cresodent. Then we cover with zinc oxide eugenol and perform the restoration of the crown. Non-vital pulpectomy. So in these cases, irreversible fake coronal as well as radicular pulp is removed to retain a non-vital primary tooth. What are the indications? Irreversible pulpitis, non-vital primary molars or incisors that need to be maintained in the arch, abscesses primary molars, and good patient compliance. It can be one-stage pulpectomy, like we say vital, and it can be two stages pulpectomy. If we use one-stage pulpectomy, we perform radiograph, of course, anesthesia, isolation, get the access to pulp chamber and identify root canals. Irrigate with normal saline, chlorhexidine solution or sodium hypochlorite solution. Estimate working length of root canals, keeping 2 mm short of the radiographic apex. Insert small files, no greater than size 30, into canals and fine canal walls lightly and gently, because you know that the form of the roots of primary tooth are not so straight like in permanent teeth. Then irrigate root canals with this antiseptic that I told you before in point 2.4. Then dry canals with paper points. Obturate root canals by injecting or packing a restorable paste. Please pay attention, resorbable paste we should use. No good aperture, no hardening materials. For example, slow-setting pure zinc oxide eugenol, non-setting calcium hydroxide paste, or calcium hydroxide and iodoform pastes. For example, Metapast, iodine, and so on. Fill the pulp chamber with cement and restore with stainless steel crown. So you see that we get the access to pulp chamber, then perform amputation, extirpation, then fill the root and pulp chamber with filling material, and then use the stainless steel crown. You can see on X-ray that it's very important X-ray control of filling of roots, that we have no excess of filling materials above the apexes of the roots, because it can lead to damage of lamina dura around the bud. Two stages pulpectomy. If active infection is present and there is presence of exudate, for example, when we have acute pulpitis or exacerbation of pulpitis, I told you this diagnosis is indicated to pulpectomy. We should, and we can't have proper drying of the canals. We perform two-stage technique, and all steps are the same, that in one-stage pulpectomy up to removal of radicular pulp. So we just, after filling the canals, if there is presence of discharge or associated with the sinus, the risk canals are dressed with non-setting calcium hydroxide and temporized. And systemic antibiotics may be prescribed. Why it's possible? Because we have sinus, and exudate will go out through the sinus. So if we have no sinus, we can use another. Alternatively, a small cotton pledget moistened in formocresol or leather mix is sealed into pulp chamber with glass ionomer cement or interim restorative material for 7 to 14 days. This technique is also known as desensitizing pulp therapy. It is also used in case of a hyperallergic pulp or when the tooth is too sensitive to remove entire roof of pulp chamber. In the second visit, the cotton ball is removed, the canals are cleaned and obturated, followed by a stainless steel crown. You can see some X-rays of this procedure. Here you can see pulpotomy, and you see that the material medicaments lying on orifices, and you can see the internal resorption. Of course, it's complication of the treatment. Here you can see the complication that excess of filling material it's iatrogenic mistake. It's near the bud of the permanent tooth. Here you can see that the first primary molar was extracted, and you can see the bud of permanent tooth and the pulpectomy and the filling of roots in second primary molars. So thank you for your attention, and I hope that this material will be useful for you for understanding this complicated topic. Okay, and my wishes, be happy and be healthy. Goodbye.